So I'd like to introduce Dr. Leighanne Parkes, who is an assistant professor in McGill University's Department of Medicine and an infectious disease specialist and microbiologist at the Jewish General Hospital. On behalf of Hope and Cope, Dr. Parkes, thank you so much for generously offering your time to come and speak with us today. We're so grateful. So Dr. Parkes, I'm going to yield the virtual microphone over to you.
Thank you. My mute button decided to disappear on me. I'm sorry. All right, everyone. Well, thank you, first of all, for having me. I really do appreciate the invitation, and thank you for the very kind introduction. So I think this is kind of a continuation of 2 years of me blathering on about this silly little thing called SARS-CoV-2 or COVID, and how it intersects with our daily lives, particularly in the context of immunosuppression. So today, what I'll be doing is I'll be talking first about what is Omicron, how is it a bit different from the prior variants of concern and from the ancestral strain that we first saw emerge. And then we'll also go into, what is the data for additional doses? How does this apply to individuals whose immune systems are compromised? What is the effect of vaccine on our immune system? And when we don't have an immune system, how does that come into effect? And how can we protect ourselves moving forward? And what does it mean that the fifth wave is coming to an end? And what does the future hold? So I'll hopefully touch on some of those. Some of it will be covered with actual visuals and slides, and other is going to be non sequiturs on the side. As you can see from the background, I'm at home in order to have a stable internet connection, and I have a cat. So if Sir Hemingway, which is my polydactyly cat, decides to walk across the screen at any time, I apologize in advance. So I'll just get started. So the first thing is, what is Omicron? Omicron kind of came onto the scene fast and furious, which is really a good descriptor of how it works. And it really is telling about why it's different from other variants. So the Omicron variant of concern, or B11529, which is just a soup of numbers that I have trouble keeping apart, was first described in early November. And it seemed to kind of crop up contemporaneously within several countries in Africa that were doing screening for specific types of mutations, and in about Hong Kong amongst travelers from this area. But it probably was around and circulating and present in the population for a period of time beyond that. So from the moment we first started hearing about this to the end of November, when we started to see the way that it moved, its kinetics, its epidemiology, at that point, the WHO said, okay, this is probably something we should be concerned about. And that's really what the surveillance of the WHO and the global community is doing. It's looking at all samples coming from individuals that get COVID, and it's saying, are there mutations here that are of concern? And what they look for are mutations that potentially cause increased transmissibility, so it's more able to go from person to person to person, increased severity, so is it going to make people more sick? And does it escape our immune system? Meaning, are we, if we've had COVID in the past, more likely to get it again from this variant? Or if we've been vaccinated, are we more likely to get it? So we examine all samples for these types of markers. And when the WHO saw at the very end of November, which made them all kind of raise their hackles, was that this little bug probably did. So by the time we had its sort of emergence, it had an influx across the world, and it has rapidly risen to be a dominant strain. And some of its substrains, which we've heard about, these remarkable Omicron substrains, are also taking center stage. And when we look at our own samples within the province and within the city, we do see that some of these sub-variants of Omicron are increasing in prevalence as a very fit variant. So The first question that we have for all variants of concern is it more transmissible? So to that, we look at the mutations. And what we see is that the mutations that were present do suggest enhanced fitness. So this guy's got a lot of mutations, a lot of substitutions in the spike glycoprotein. So when we think about the spike glycoprotein, it's like the key that sits on the top of the virus. And it's the key that enters the human cell lock and allows it to get into human cells. So if that key becomes the best fit, we're not just jamming anything in there, it's a perfect fit. It's going to enter with greater ease, with greater affinity, and it's going to act as something that is more transmissible, more infectious. So what we see is that there's 30 sort of tiny substitutions, so very small mutations within this part of the virus, including some that are in a very specific part of the receptor binding domain and the receptor binding motif, which are just in the exact points that allow the binding of the virus to the human cells that allow it and to enter the cell where it can replicate. Now, this has implications not only in the ease of transmissibility, but since our vaccines target the spike glycoprotein, then it might also have implications with respect to potential efficacy of vaccination and the potential for immune escape if you've had prior COVID infection, because we do know that we really do create a lot of antibodies against this molecule when we have natural infection. We also see some changes in another domain, which enhances its ability to fuse with the cell. There are mutations in spaces that are targets of neutralizing antibodies. And we hear about these a lot in the news because they might indicate that they would be less effective, or that it would render less effective some of our treatments that are called monoclonal antibodies. So the treatments that target the spike protein that you can get when you're acutely infected. So initially, after they sequence the virus, they say, okay, let's do computer modeling to sort of see exactly what this constellation of mutations can do based off of what we know about these mutations in other variants. And some of these mutations were present in Delta and other variants. So what they see is that the spike protein mutations can lead into alterations in the human ACE receptor binding. So it binds better, so higher affinity, compared to other variants. So the 6 mutations enhanced binding affinity by about 2.4 times. And the question is, having more, is that additive or does it work against each other? So higher affinity, probably better. But there's also some suggestion that having a weaker or less stable affinity might create a different effect. So it could slow the uptake of the virus into the cells, which actually delays our immune response. So we're getting the virus, it's entering slowly, and our immune system's kind of walking by and they're going, oh, is there something there? Nah, it's just my imagination. And they keep walking. So that could actually play into why it's actually escaping our immune system a little bit more. And the mutations that are in that sort of fusogenicity area, the furin binding domain, can enhance infectivity. So this is the piece that basically cleaves off the bit that you need to enter the cell. So all of these things together suggest that the virus over time, with all of these opportunities to replicate in human hosts, has become or has evolved to become very efficient in doing its job, which is to survive, to create more of itself, which is not surprising. So the question is, what is the epidemiology? These are, mathematical models. They're based off the mutations. They're based off of, data from prior viruses. But what do we see in the real world? Now, we are, even though we're hedging into March, this has only really been around in mainstream kind of since the end of December, around Christmas time. So we don't have a lot of data or a lot of time to have observed this. So much of our data comes from the sort of first hit countries, and a lot of it is still emerging from other places. And you have to remember that Wave 5 was a little bit unique. You could see it in terms of our own government's response as we were overwhelmed by the crashing tsunami of cases. there was a decreased ability to really track like we did in previous waves, where we would test everyone. So that wasn't happening. People were just told, oh, if you have symptoms, stay at home, stay isolated for 10 days, maybe do a rapid test if you have your hands on it. So we weren't really collecting the same amount of data in a lot of jurisdictions. So it's really hard to get a clear picture at this point in time. But hopefully, and I know that there's other areas that are publishing on this, these things are going to become more clear in the months to come. But what we saw is that it is very fast. So it rapidly doubles. So doubling time in about 1.5 to 3 days. So that just means that it's moving from person to person very, very quickly compared to the other ancestral viruses, which tended to take their time to move through communities. And we actually just saw that, right? Think about this. This all really started, things went into lockdown in December. We went this sharp peak up, we kind of plateaued. Now we're coming down. So that's super rapid compared to prior waves where we started in October, we finished sometime in May, and it felt like the longest, coldest, worst winter of ever in the history of time. So this is very, very fast. And we know from Denmark, where they've published really well on their first 785 cases of Omicron, and they linked these to 80, or at least 83 of these cases to 5 large events, suggesting that, big group settings where you're not masked are really important. So it does still have that super spreading capacity. And it attacks a large portion of the population, meaning it's very infectious. So they have one gathering of 150 participants where the attack rate was 47%. So you had one person with the spread to 47% of the individuals in that group. So it's very, very infectious. And they found that the doubling time was somewhere between 1.8 to 3.2 days, meaning that they had more and more cases during that time period. And we saw that ourselves. If you think back to over the holiday period when they were reporting our numbers with some accuracy, it seemed every day it would go up. You would be at 6,000, and then within the next few days, you'd be at 12,000 cases reported for the province. So when we look at Ontario, which also got hit and was calculating some of this, the growth rate was found to be 48% faster. And then that was compared to Delta, which was already pretty fast. Again, we see this also in South Africa. So South Africa with Omicron was 3.3 times more transmissible than Delta with a more rapid spread. They found that the transmission advantage was probably gained by immune escape rather than by an actual inherent increased transmissibility. And this was really described by like an amazing Japanese epidemiologist, Nishiuria. So this individual initially described the ancestral strain, or the first huge amount of data that came out of Hubei province in Wuhan, and as it spread initially, all we know about the epidemiology of COVID has come from a lot of his work. So to see this sort of hypothesis based off of the data that he was looking at in South Africa is very interesting. It suggests that if we're able to evade immunity in this way, then we can see something that's more transmissible. And it's not necessarily that it's just the virus, zips through the air faster or whatever. It is evading our immune system. So the UK also saw a rapid doubling time. At the peak, they actually had less than 2 days and less than 24 hours. What else we look at is the incubation period. So we see that this moves very, very rapidly. It attacks a lot of people, and it's very efficient at causing infection. And it's probably because it's escaping our vaccine-mediated immunity. But what's the other aspect to it? Why is it moving so fast? And that's probably because the incubation, the time between infection to onset of symptoms, is shorter. So it's collapsing in. So the median incubation period has been described as more than 5 days. And this was for the ancestral strain, about 4 days for Delta variant. And when we look at the clusters in the Norway Christmas party cluster and the US cluster in Nebraska that was linked to a traveler, we're looking at about 3 days as a median incubation. So it's shortening. So it's much more efficient. It causes a sharp peak and then it diminishes. So we also see that it causes a lot of disease within the household. And this is actually quite interesting because this Danish study actually looked at the effect of vaccine in a household. So this is where we kind of want to perk up and we want to say, okay, does vaccine actually work? So we see high secondary attack rate. So it's 31% for Omicron versus Delta. So it infects more people than Delta did. And we know that, right? We've seen it. What we see also from their study is that you had more transmission within a house if you were unvaccinated. And if you were vaccinated, specifically if you had a recent booster, you had reduced transmission. So this was the first inkling that having a recent boost or a recent dose of vaccine actually reduced in less transmission within a household. And think about it, a household's a place where you're sharing air, you're sharing saliva, you're sharing everything with the people in that space. It is an area where we have the highest risk of infection and transmission. So what we see here is that vaccines, even though this little bug can escape vaccine, this variant can escape vaccine, it does actually have effect at reducing transmission. So when we look at other secondary attack rate estimates, something more close to home, like UK data, we find that it's twofold higher than Delta. So 21.6% for Omicron, 10% for Delta in the UK. And it seems to also have a similar proclivity for super spreading events. So this was the one that I described a bit earlier, which is the Christmas party in Norway. What they had was 117 individuals that attended with a mean incubation period or median incubation period of 3 days, very short. They found that majority were symptomatic. Most cases and non-cases were non-vaccinated. So they found no difference between the two groups. But good news was no hospitalization, and they had a very high attack rate. So 3/4 of people in the Christmas party actually were infected with this. So this shows sort of everything that we've seen from the other data, which is that it moves very rapidly. It might have less severe disease. Individuals that are vaccinated can get it. And it does attack a lot of people within the population. It's probably related to its immune escape. So when we look at reproductive numbers, so how many individuals get infected from one person, this is sort of gives an idea of the transmissibility and also the dynamics of the virus. It is higher than Delta. So we have data from Denmark, South Africa, and from Ontario in the Kingston area, which had a very large outbreak early on. And what we see is that the effective reproductive number is about somewhere between 1 to 4 times greater than compared to Delta. So in Ontario, they said 1.5, and these were really linked to outbreaks in post-secondary schools and food and beverage settings, so bars and restaurants, so places where you're in tight enclosed spaces, poor ventilation, and you're mask-free. In South Africa, they found that the reproductive number was about 4.2 times greater than Delta. And this is in a population that had low vaccine rates, but high prior immunity. UK similarly 3.7, and in Ontario with longer term data, they found that it was infecting 3.5 times more individuals than Delta, so a higher rate of infection. So there was some suggestion that there's a high degree of asymptomatic shedding. Now, this is also panned out locally in some of our descriptive epidemiology in our outbreaks. So we do a lot of asymptomatic screening whenever we find one positive case in long-term care. So these are individuals that are highly susceptible to severe disease, and we find a very high proportion that are asymptomatic. This study was actually coming out of South Africa. It was a study that looked at pre-vaccine testing of individuals who had, or persons living with HIV. And what they found was that 31% of the individuals with no symptoms prior to getting their vaccine were actually positive for Omicron, so they had the disease. And they found that they were quite infectious. So they had cycle threshold values that were low. So the thing about cycle threshold values, this is when we do a PCR test. What we do is we take a sample from a person and we multiply that sample. So we amplify. So we do these little cycles where we try to double the amount of material in that sample. And each cycle we double the material. So if you don't really have to do many cycles to get enough material to say, ding, this is positive, then it indicates that you started with a lot of material initially. So the lower the cycle threshold is, the higher the amount of virus that's present. So these individuals were very infectious, but they were having no symptoms and they were not vaccinated. So it does also point towards the possibility of less severity. So it might be too soon to say, does it cause less severe disease? And I kind of wrote this slide a few weeks ago based off of data, and data is still coming in, but there is some early studies and more data that do suggest that it does produce less severe disease. And it's hard to say whether or not it's inherent to the virus itself, or if it is now, or inherent to this variant itself, or if it is now because we do have a baseline populational immunity, either by prior infection plus vaccination or vaccination. So when we look at South African data, the risk of hospitalization was 29% lower compared to the other strains or other lineages. And Pfizer vaccination had 70% protection against hospitalization and 33% protection against infection. So there was retained vaccine efficacy. UK, they found that somewhere between 30 to 45% of people presented to the emergency department were less likely to present to emergency department, and 50 to 70% were less likely to be hospitalized. Scotland, 65% less lower risk of hospitalization, and the third dose that they gave in Scotland reduced symptoms by 57%. Denmark, only 1.2% of that 700 person group were actually hospitalized, so a very small proportion. And when we look at the European surveillance system, which takes into consideration multiple nations across the EU, what we do find is that 11% were asymptomatic and only 1% required hospitalization. Now, if 1% requires hospitalization, that seems like a very small amount, which it is. But if you have a large proportion of your population that at the same time gets infected, that 1% can be a very big number, which is what we saw locally. So even though we had a lot of cases, particularly in individuals that were very susceptible to severity, like our long-term care elderly population, we didn't see the same degree of necessity for hospitalization in that group as we did in prior waves. So it does suggest that vaccine helped. Plus or minus, this variant itself did lose some of its bang with respect to its ability to cause severe disease. So in Ontario itself, the risk of hospitalization was 65% lower. This was in a matched cohort study. Ooh, my automatic cat feeder, so he's active right now. This looked at over 11,000 Omicron cases, and they found the risk of death or hospitalization had a hazard ratio of 0.35, and the risk of ICU admission was 83% lower compared to other strains. So much, much improved or decreased risk of infection of hospitalization or ICU admission. So what happens to our vaccines? So what we do see is for Omicron versus Delta, there is an increased waning of immunity. So over time, from our second dose or from our booster, it seems as though our antibody titer goes down and our ability to sort of neutralize the virus decreases. So this study was really, really nice coming out of the UK, one of the first groups of data that we had showing that the Pfizer primary course, 75.5% efficacy after a Pfizer booster. This was retained for within about 3 months. So by about 10 weeks, you lost some of that efficacy to 45%. And this is again, symptomatic infection. This is not against severity. That was still really high throughout. And when we look at Moderna, and Moderna had a bit of a sort of leg up because they had a higher second or boost dose instead of half dose that was given in some instances in some jurisdictions, that about 9 to 12 weeks, they still had retained efficacy at about 70 to 75%. And this is again, symptomatic infection. Severity for both groups still remained protected throughout that period of time, and hospitalization. So we also see reduced but preserved efficacy in South Africa. So the efficacy was about 50 to 70% after 2 doses of Pfizer. And this is for hospitalizations. And what we see though, is that the 3rd dose really does increase neutralization. So 2 doses at a mean of 166 days, no neutralization efficacy against Omicron. So this is like our antibodies are standing at the door, the virus comes in and they encapsulate it and they say, no entry. So at 2 doses that far out, it's not really doing much of anything with respect to those antibodies. 3 doses at about a month after that 3rd dose, they were very, very efficient at stopping it. So efficient neutralization of infection. It was higher by a factor of 100 in terms of neutralization efficacy, but it was a bit lower compared to Delta. So the 3rd dose, really, really high, but less effective for Omicron than Delta. But what we don't know yet, and what we're still trying to figure out, is how durable is this? What happens over time? Where are we going to be at 6 months? And that is still to be told. So vaccine after infection increases neutralization. So this is even better. So if you had COVID, you got vaccinated and you got boosted, you're set. Your the vaccination of recovered or a 3rd dose had a substantial gain in neutralizing activity. And it's about 154 times greater for Omicron if you're vaccinated after being recovered, and a 3rd dose was 38 times greater. So for those that had COVID and got vaccinated, you have a much more robust immune response and neutralization response in these studies. So this is all antibodies, but what about our cell-based immunity? And this is something that we take into consideration possibly when we think about things like severity. So there was a modeling study that looked at the specific motif of mutations for Omicron and the T cells that would be and T cell specific epitopes that would have been generated from vaccination. And what they did see is that it was probably preserved. So the large majority of about CD8 and CD4 T cell epitopes remain unaffected by Omicron mutations, meaning that this lowers the possibility of T cell escape. So even though those antibodies are there, those T cells are in the wings ready to go, which is probably why we saw preserved decreased hospitalization, decreased severity, and increased rates of asymptomatic or minimally symptomatic infection or disease. So how does this affect immune compromised individuals? And I'm so sorry, this was supposed to be split into 2 slides, so it's very wordy and it is bothering my eyes, so I'm sure it's bothering yours. So we'll start by unpackaging it. And if you want to look at these resources, they're actually pretty good, including the Lancet one is very readable. Individuals that are immune compromised, it's a heterogeneous group. And we know that depending on what type of immune compromising state you're living with in terms of the medications you're taking, your underlying malignancy, and where you are in your treatment. All of those things create a effect on an immune system that is highly variable. So it's very hard to say immune compromised under one umbrella. But what we can say is that we do know from accumulated data since the beginning of the pandemic that individuals that have poor immune systems are more susceptible to getting COVID-19. These individuals are more likely to have the greatest consequences of COVID infections, including more severe disease and higher risk of mortality. And we also know that these individuals are less likely to mount a sufficient immune response to a COVID-19 vaccination. So this seems, just reading this, very disheartening, because it seems like, where is our recourse here? Well, there is something to unpackage. So we know that there's reduced protection against symptomatic and severe disease, and there's an increase of hospitalized breakthrough cases. So immune-compromised individuals are greater than 40% of those vaccine breakthrough cases that end up in hospital. So those are the individuals that are in the ICU that were vaccinated at the onset of sort of the post-vaccine breakthrough phase. But a lot of data has looked at what are possibly the effects of adding an additional dose to the primary series. So this is not a booster, and this is sort of the nuance. For the whole population, we talk about a 2-dose series, and then the 3rd dose, which was given as a booster to the series. For immune-compromised individuals, the primary series is a 3-dose series, and this is what really the data has shown is probably the most effective thing. So what they found, and there's a few studies that look at this, is that the seroconversion rates after 2 vaccine doses in people who are not immune compromised was about 99%. So it works really well. If you have a solid cancer, it's about 92%. If you're on immune-mediated, if you are immune modulators in terms of inflammatory disorders, so rheumatologic conditions with certain types of medications, 78%. If you have a blood cancer, blood bone marrow cancer, it's about 64%. And if you are a transplant recipient, 7%. So it does decrease with respect to immune compromising condition. However, giving a 3rd dose as a primary series can improve that. So what they saw was, and this was this study here that was published in Lancet Global Health, looked at 2 randomized control trials and 21 observational studies of a heterogeneous group of immune-compromised individuals. And what they found was that having that 3rd dose as part of the primary series did increase the median antibody response from 41% to 67%. And this is across all comers. So you can see from the graphic on the side that depending on the type of immune compromise, you might have a flattened or less response. What they also found, though, was in those individuals that had low or absolutely no antibody response after the first 2 doses, they found that an additional dose, that 3rd dose, had a mean antibody response rate of 44%, meaning that 3rd dose actually induced a response. So there was hope for those individuals that after 2 doses had absolutely nothing. So to blanket statement say, if you are immune compromised, you have no protection from given to you by these vaccines, that might not be true. Because what they see, though, coming out of the UK and UK data, is that a good proportion of individuals that didn't respond after those 2 doses responded after that 3rd dose. So that is why 3-dose primary series is the recommendation for immune-compromised individuals. Now we'll talk about 4th dose in a second. So just to summarize this, because this I think is really important. So the additional dose, that 3rd dose, doesn't simply increase an existing antibody response, but it actually is capable of inducing a new response in those that didn't mount one. So that's the important aspect to this. So what about this 4th dose? And what we see, though, is in Canada, so NACI has recommended it for individuals that are immune compromised, moderately to severe immune compromised individuals. This is also picked up by our local guidance in Quebec. We also see in other places, Ontario is using it for immune compromised and individuals in long-term care facilities. So they've very elderly, very infirmed, doing a 4th dose. So this would be sort of like the boost to the 3-dose series immune compromised individuals. What evidence do we have for this? And the answer is not a lot yet, but we do have some inkling that it might be effective. So UK has 2 studies, the Octave study, Octave Duo. The Octave study looked at the 2 doses immune compromised, Octave Duo 3 doses. Octave Duo hasn't published yet, but they really do show that that 30-dose series really does support, and they're trying to nuance exactly how that plays out in real life. The most interesting one, and this is the data where I suggest everyone look out for, is the UK MELODY study. So they're looking at the proportion of immune-compromised patients who have detectable antibodies after their 3rd and 4th doses. And what they're looking for, and what the thing that I think all of us want to know, is how does this correlate to the risk of infection and the risk of severe disease? So does this actually protect us? And that's the information we need to know. So the UK is working on it. They do have some preliminary data that is very positive, but nothing is published as of yet. There is some data out of Israel, and this has a caveat of being in a healthy population. So they reported, and this isn't published anywhere, so that's not peer reviewed, that there was a 5-fold increase in antibody levels, increased protection against infection, hospitalization, and severe disease in those individuals that had a 4th dose. And this was a 4th dose about 6 months after their 3rd dose. So it's unclear whether or not it will be recommended for the whole population, or the 4th dose will just become the booster for the immune-compromised population who have already a 3-dose primary series, as opposed to the normal population, which has a 2-dose primary series. Right now, I can tell you that there is a lot of data being collected prospectively in Canada and the US, which have rolled out a 4th dose in this population. So they're looking very closely, similar to the MELODY study, to see what is the additive effect of this. So we don't know. So vaccines work. And I think immune-compromised condition or not, vaccination is important. What you can do is you can talk to your healthcare provider about the best timing for vaccination, depending on whatever therapy course you're on. And they're the ones that are going to know what your immune system is going to do at what time in its course. So stop in with them, and they can call me, and we can discuss. But what is really important is to optimize when you get the vaccine relative to some therapies. If a therapy can't wait, then it can't wait. You go ahead, and vaccine is of secondary importance. But sometimes we can optimize our immune response by timing it with respect to where we get certain types of immunosuppressive therapies. Now, the other thing we can say is when you have a really high amount of virus or amount of transmission in the population, wearing a really good mask is important. So we do know with time, and particularly with Omicron, its immune escape, its high transmissibility, that there's a higher risk of short-range aerosol transmission, meaning that you really want a good, tight-fitting respirator. So this is an N95 respirator or equivalent. And this should be applied in high-risk settings. So if your immune system is not super good and you're going to a place where you're going to be in a closed space that's poorly ventilated with a lot of individuals who are not wearing masks, having one of these on will be protective. When you're in, and this is predominantly in high periods of population-based transmission, social distancing. So social distancing and fastidious hand washing and mask wearing when you're in a big wave. Is this going to be like this forever? Probably not. And the reason for that is kind of related to herd immunity. As a lot of the population gets Omicron, and as more and more people get vaccinated, then less transmission is going to occur. And we can relax even as individuals that have a less immune response or a less robust immune response. And that means just doing sort of a risk assessment of whatever situation you're going into and saying, hey, is this going to put me at risk based off of what I know about what's going on in the population right now, and about what activity I'm engaged in, and based off of that, you can wear a mask or appropriately decide not to attend a certain event, or you say, hey, we're in a situation where we have almost zero cases being transmitted. And the risk for me in this instance, because we're outdoors, we're in a good ventilated space, and most people are wearing masks, is really low. Those are sort of the situations where we can live normally. And I think that's where we're going to be moving towards as more and more people in the population develop immunity. What it does is it protects those who cannot develop a robust immunity. And then the last thing is early treatments. And we know that these are very effective. So Trovimab is available in our province for any individual who's immune compromised, who might not have an adequate response to vaccination. So if you are to get infected with COVID, you present as soon as you can to a healthcare setting, or talk to your primary care physician or your oncologist about receipt of Sotrovimab, and we can give that to you, and it can dramatically decrease the risk of hospitalization or severity in those individuals that can't mount immune response. And this is a monoclonal antibody that does the job of an immune cell, like an antibody that would be generated by your vaccine. So it goes to work in a similar way, and it binds to the virus and it prevents it from doing its job. So there's other things other than vaccine out there. The world, as we move out of wave 5 with increasing amount of immunity in the population, is going to gradually return to normal. And it can return to normal safely, even for immune compromised individuals, because there's going to be less transmission, less risk of exposure. And there's also sort of in the wings treatments available for populations that might still be at risk, even as the virus does wane within the community. So those are all very good signs that within the next few years, we're going to be out of this. So I think maybe I'll open it to questions now.
So Dr. Parkes, thank you so much for this presentation. I'm actually just going to jump in. I know earlier we said to unmic, due to the amount of participants that we have, we're actually, if you have any questions, I'd encourage you to write them in the chat box, as some have done. I believe most of the questions that were sent in ahead of time were answered. If there's something that's not clear, I do want to put a little disclaimer, as Dr. Parkes has also mentioned. We don't have access to all of your records right now. Dr. Parkes can't give specific advice. As she mentioned, we recommend consulting with your medical, oncology, any part of your care team that has your full medical history, as well as all of your records, to be able to give you the best advice possible. We don't want to overstep any boundaries. So some of the questions, Dr. Parkes, that just have come in. Are you considered immunocompromised if your only issue is slightly lower than normal white blood cells?
So that would depend on sort of what the altogether state is. So like white blood cells, depending on what type of white blood cells they are, or whether or not there's concomitant decline in immunoglobulins, all of those play a role. Like our immune system is very complex, and it has multiple layers of redundancy, and it's like that for a reason, right? So if one sort of arm of it gets attacked or goes down, we have other possibilities to rally and to help protect us. So certainly, if you have a very dramatic decrease in all of your white blood cell lines, you're not able to make neutrophils or any type of lymphocyte, then your ability to respond to any infection can be very low. So individuals with certain types of primary immunodeficiencies, where they can't make any type of real immune response, can have severe consequences from what we would consider relatively benign viruses, like even rhinovirus or respiratory syncytial virus, things that cause a little bit of sniffles in a normal host. So it would all depend on specifically the cause and the type of cell defect. But yes, certainly it can create problems with respect to vaccine response and to ability to clear virus. But also it depends on the degree of underlying deficiency and what else is happening.
Perfect. Another question. I'm reading through them, everyone. So hold with me for a moment.
Sorry, what if people are not on chat, they're on audio? How do I write my questions down?
On the bot, if you're joining by phone, you might not be able to add to the chat. If you're just on a phone with, so I don't know if I can't really fully hear you.
Yeah, I keep putting myself on mute to help you guys out. But I just have a quick question, if I may.
Yes, since you're on the phone, you can go ahead and ask your question since you don't have the option of the chat box.
Thank you so much. I was just diagnosed with invasive ductal carcinoma, and I had the 2 vaccines, and I had a shingles vaccine, and they noticed I had enlarged lymph nodes. So they said it might have been because of that I had a not regular routine mammogram. And my question is, now I have to start treatment for radiation, and is there any evidence that shows the booster vaccine will cause any problems? Because I've had bad reactions before. And my household is all triple vaccinated, but will I benefit from getting the booster? I guess that's my main question. I'm a little nervous to add any more things to my body.
So I just, from what I've heard, and again, I'm not a medical professional, so Dr. Parkes, correct me if I'm wrong, that would be a question specifically for your oncology team. In the situation of if it would affect your treatment, or if there could be some reaction. I think that your medical team would be the best people to ask in that situation.
Okay, because I asked my oncologist, and he said I can do what I want. So I guess that means I should or I shouldn't. I mean, I don't know who to ask.
Sorry, I missed a little bit because of the audio, and also apparently my hearing's not where it used to be. So the question was whether or not to get a 4th dose of vaccine in the context of planned radiotherapy, correct?
A 3rd. I didn't have the booster yet. I only had the 2 vaccines. I haven't had the booster yet. I had the 2 vaccines, and I had a shingles vaccine, and then I was diagnosed with cancer. So now I'm just wondering, will the booster, is it beneficial for me to get? I mean, everyone says it's beneficial, but when I asked my oncologist, he said I could do whatever I want. What does that mean?
Yeah, so I think the 3rd dose in just normal population is actually quite beneficial with respect to Omicron. Kind of what we've presented thus far is that there's a lot of waning immunity. So if you're outside of about 3 to 5 months from your 2nd dose from your primary series, then you essentially don't really have any more neutralizing antibodies to prevent you from getting Omicron. It can still, those two doses can still protect you against severe disease and hospitalization, but you could still be infected, which can be pretty miserable. So one of the ways to protect yourself is to get that 3rd dose. Now, if you've had any type of reaction, I heard something about lymphadenopathy or swollen lymph nodes. If you've had a reaction to a prior vaccination, your oncologist can refer you to one of the allergy immunologists at the Jewish General Hospital. They're really great. They can look at your case, and they can say whether or not it's a contraindication to having additional dose, and whether or not you need additional monitoring after your 3rd dose. So that's kind of how I would proceed based off of the information that I have. I hope that helps.
Very, very helpful. Thank you so much for taking your time. Thank you. It's very, very helpful. I'm scheduled for the booster on Monday. I'm definitely going to go. Thank you so much.
So another question, I'm going to combine a few questions. I hope that's okay. About mixing doses. So is it okay to mix Pfizer, Moderna, AstraZeneca, and if you received one, should you receive a certain one for your second or third?
Yeah, so for the first and second, it's usually, well, what was being done is the same dose, with the exception of AstraZeneca, where they did change it to a mRNA because of the risk of vaccine-induced or VITT, which is the thrombocytopenia and thrombosis. So what we see from the data, and it's really funny, kind of the best combination is to get a Moderna as a third dose, and at the full dose. So instead of the 50, the 100. And that seems to create the most robust and the longest durability of immune response based off of the UK data. I'm a little bit unclear as to why that is. I tried to look at specifically what piece or how large of a portion of the spike protein they're using for Moderna versus Pfizer, and I couldn't find that information in any way that was, cohesive. But my hypothesis is that you might just have a bigger portion, so you have more places that you could maybe create antibodies to target versus a smaller portion. So I think, if you have the choice, I didn't. Otherwise, I would have been like, Moderna, please. I would probably elect Moderna, but I think that's all that's available in most places in the province right now anyways.
Perfect. Another question, how long on average are you considered immunocompromised after finishing treatment?
That is an excellent question. It really does depend on the type of treatment you've received. So all immunosuppressing therapies are very different. So an example, rituximab, which targets B cells, can last for a very long time. So you could have dysfunction for 6 months and beyond. Versus, prednisone, which once stopped after several weeks, you don't have a noticeable effect for your immune system. So it really does depend. Your immunologist or your oncologist would know specifically the sort of time delay for how the immune system will rebound after your therapy. And in some cases, it's pretty fast in the manner of weeks. And in some cases, it can be quite delayed.
Perfect. I think that answers another question about a specific treatment and how long the individual would be considered immunocompromised. Can you receive sotrovimab without going to the hospital? Can it be prescribed by a primary physician?
Yeah, that is also a good question. So most of that information is available on the INES website. Generally, what's been happening within our CIUS is an oncologist will hear from one of their patients that they have tested positive. That oncologist will call one of the microbiologists on call, discuss the case. And what we do is we arrange for the dose, because it is an infusion, kind of like getting like IVIG or any type of infused chemotherapy. We arrange for it to either happen in the emergency department or in medical day hospital within the Jewish General Hospital. So that's kind of the process that we have in place. If you're part of our CIUS, definitely do that. And the dose can be given accordingly. It has to be within 7 days from the onset of symptoms, however. So it's one of those things that it's best not to delay.
Perfect. I think that's a great answer. So I want to apologize in advance for anyone who asked a question about a specific situation. I'm going to redirect you, and I think Dr. Parkes, you agreed earlier. Please consult with your medical professionals regarding how many doses, the dosage itself, the makeup of the company of the dose, because your medical team is in the best position to answer that in relation to your specific situation, especially with your condition, your treatment options. Dr. Parkes obviously doesn't have access to your chart right now. The last question for today that we're going to ask is, how long does it take? And I'm going to elaborate. The question was, how long does it take for the 4th dose to kick in? But can you also, I guess, for some people getting boosters, how long does it take for the 3rd or 4th dose to kick in?
Yeah, so it's kind of gradual, right? So we see that there is an increase at about 7 days, and then beyond 14 days, that's when you really have good bang for your buck. But by day 28, you're probably at the peak that you're going to reach. So certainly I would say at 14 days, you have a very good response to either your second dose in a primary series, or your third dose in your primary series if you're immune compromised, or your booster in either case. But beyond that, it really does sort of plateau at a high at about 28, 30 days. And the million-dollar question is how high and how long is it going to remain like that? And that we just don't know.
So one other question that I totally wanted to ask, I just forgot, and I think it's very relevant to this population. Somebody asked, why do immunocompromised individuals need to isolate for 21 days compared to the rest of the population that has different guidelines?
Yeah, so it's the reason for that is based off of studies where we've done viral culture in individuals that have poor immune systems. And we've found that they tend to be positive for much longer. So whereas a counterpart who has an intact immune system will clear the virus in about 7 or 8 days, an individual that's immune system is impaired, or someone that had severe disease. So let's say a normal human or a normal immunocompetent host that ended up in the ICU on steroids and all kinds of things because they're very severe infection, they also don't clear the virus as fast. So by about day 20, 21, we find in the vast majority of those cases, there's no more detectable, cultivatable, and therefore infectious virus present. So that's why the 21 days is there. That said, if you are profoundly immune compromised, so individuals that have received things like CAR T therapy, have had allogenic stem cell transplants and graft versus host disease, you might actually have infectious virus for much longer. And that's been reported in the literature beyond 100, 200 days. So those individuals can be have prolonged infections. And we've seen that with lots of other respiratory viruses. We've seen that with rhinovirus and RSV. So it's not surprising that we're seeing that with COVID as well.
Perfect. So Dr. Parkes, I just wanted to say thank you so much again. This was so informative. I hope that everyone that joined, some of your questions were answered. If not, we again recommend speaking with your oncology and your primary care team. Dr. Parkes, thank you so much for taking the time out of what I'm sure is a very busy schedule to be with us today and to answer your questions. So the conference is now over. We just wanted to remind you of our upcoming 2 webinars that I mentioned earlier. All of the registration information is available on Hope and Cope's website. We thank you all for participating, and we wish you all a wonderful afternoon. Stay warm and stay safe on the ice. We know it's very, very slippery out, so be careful and have a great one, everyone.